All right, we are right at the top of the hour. Hello, everyone. On behalf of the National Alliance for HIV Education and Workforce Development, I would like to welcome you to our monthly webinar series and thank you for participating. Before we begin, I would like to review some housekeeping items. We invite you to use the chat to engage with your fellow attendees. Today's session will be recorded. The session recording and the PDF of the presentation slides will be added to NAHUD's website as a resource. You will receive this information in the post-webinar email that will be sent out through Zoom. You can also visit NAHU's resource page on the website to find this resource and view past sessions. Throughout the session, please use the Q&A pod to ask your questions. The speaker will address them at the end of the presentation. If there is time and you would like to ask your question live, please raise your virtual hand and I will open your line to speak. NAHUD is a membership organization of 8 regional and 2 national AIDS education and training centers. Established in 2010, NAHUD supports the ATCs, a component of the HRSA-funded Ryan White HIV and AIDS program, which have an explicit directive to build and maintain a well-educated and culturally sensitive health professions workforce that can provide prevention, diagnosis, care and treatment, and medical management for people at risk and living with HIV. NAHUD collaborates with multiple organizations to promote and educate on the work of the ATC program. Since 2018, NAHUD has been funded by the American Academy of Addiction Psychiatry as a partner organization of the Opioid Response Network to address the intersection of HIV and opioid use disorder. ORN was created to support efforts in addressing the prevention, treatment, recovery, and harm reduction of opioid use disorders and other substance use disorders through the provision of locally designed education and training. Visit the website to submit a TA request, read case studies, see featured resources, check out upcoming ORN training and events, learn about ORN work groups addressing health disparities, and more. We value and welcome your feedback on today's webinar. We will include a link to the evaluation towards the end of the session, and it will also be included in the post-webinar email. Please complete it within the next 2 weeks. If you are requesting CE credit or a certificate of attendance, you will need to complete the evaluation. To receive contact hours for participating in the continuing education program, the registrant must join the webinar, attend the entire presentation at least 80%, and complete and submit an electronic evaluation. A certificate of completion will be distributed within 3 weeks of submission of the evaluation. I would like now to introduce the speaker. Today, we have the pleasure in having Dr. Anu Hazra, who is an assistant professor in the section of infectious diseases and global health at the University of Chicago and the director of STI services at the Chicago Center of HIV Elimination. He is also the medical director of the DCAM Sexual Wellness Clinic, providing comprehensive sexual health care to patients entering the University of Chicago Emergency Department with STI symptoms. His research and clinical interests center around sexually transmitted infections and their impact on gender and sexual minorities. His other interests include complex HIV management, hepatitis C treatment, high-resolution anoscopy, treatment of opioid use disorder, and medical education. Above all, he is passionate about the equitable delivery of healthcare to LGBTQ people of color.
Awesome. Thank you so much, Ashley, for the introduction. I'm so happy to be here. We have like a really lively group and reading through the chat. You guys are coming from some amazing places doing some great work. I think we can sort of jump right into this. These are my financial disclosures. And these are our learning objectives today. So I'm really hoping that we can sort of all understand the unique challenges and the intersection of substance use disorder and HIV and STI vulnerability. Also sort of exploring evidence-based approaches and as well as cutting-edge interventions and how we think about and redefine our traditional prevention methods, specifically thinking about biomedical prevention for HIV with PrEP, as well as biomedical prevention for STIs with DoxyPEP. And we'll be talking about newer data with that. And then lastly, really equipping everyone here with the practical knowledge for implementing these interventions and trying to take a proactive role in reshaping how we think about prevention for people with substance use disorder in 2024. Looking through the chat, I think this is maybe a slide that everyone is really familiar with, but something I do still always start my my talks with. I think it's really important for us to recognize the power and importance of language, and including understanding that no disease, process, or pathogen really defines a person's life or livelihood, and our language really needs to reflect that. And unfortunately, I think in research talks and even in papers and whatnot, people still use terminology like HIV positive or HIV infected when we really should be thinking about people with HIV. In the same setting, when we think about sexual behaviors, I think my life's mission is to remove the terminology unprotected sex from everyone's minds and really trying to be more sort of deliberate with what we're trying to get at. Unprotected sex and risky sex, these, confer connotations of morality on folks, and really important for us just to be precise with what we want to talk about. Are we concerned that they're not using condoms? Then just say condomless sex. Or are we concerned that they're engaging in sex work or survival sex or other ways that are putting them at vulnerable positions for infections, and then say that. And in the same way, removing terminology like injection drug user or drug abuser, and really saying this is someone who injects drugs or substance misuse in general. So let's talk about the epidemiology and landscape of HIV currently. So, we're seeing that diagnoses of HIV in the United States are slowly decreasing over time. And, we've seen a, 18% increase from 2020 to 2019, but this is largely an artifact from the COVID-19 pandemic and decreased testing that occurred during that time. But in general, we're seeing a small drift downwards of new infections, which is great, but certainly not the same rate that we need to see in order to end the epidemic. We also recognize certain groups are disproportionately impacted or affected by new HIV diagnoses. These include Black and African American men exercise with men, Hispanic and Latino or Latinx or Latin men exercise with men, and specifically Black cisgender women as well. And with that, understanding that racial and ethnic differences do persist in terms of new HIV diagnoses, specifically around Black and Brown Americans in this country. And we'll talk about how this is all impacted how we think about this endemic and how systemic issues impact how we're seeing new diagnoses in this country in general. And the other major factor to think about is geography. That South makes up more than half of all new diagnoses in 2021. That if you add up every single other part of the country, new diagnoses together, you still would not exceed the number of new diagnoses we were seeing in the Deep South and the Southeast of the United States. And again, going back to sort of systemic issues that we are seeing across the board that are impacting folks' ability to access prevention and other tools to protect themselves from HIV. About 1.2 million Americans in the United States are currently living with HIV, but about 1 in 8 of those do not know that they have HIV, and roughly 1 in 5 already have advanced HIV or AIDS at the time of HIV diagnoses. So before we can even talk about HIV prevention, we have to talk about HIV testing. That we've talked about what proportions and populations that HIV disproportionately affects, but understanding that if we're not going to be screening the people we need to for HIV, there's no way to even have the conversation or space around the conversation for prevention. And in general, if the current trends continue, we're going to be seeing additional 400,000 people in the United States diagnosed with HIV in the next 10 years. We're headed, again, not in the correct trajectory of eradicating new diagnoses of HIV in this country. And in the same way, we're seeing again an explosion of STIs across the board, rises in gonorrhea, chlamydia, and syphilis, and most concerningly, congenital syphilis in this country. That again, the increases we are seeing are disproportionately impacting young people, gay, bisexual men, pregnant persons, and racial and ethnic minority groups across the board. And specifically, the most concern for congenital syphilis, seeing that, again, as of 2022, looking at live births and reported cases of congenital syphilis, seeing Black and African American and Hispanic and Latinx populations disproportionately impacted by this completely preventable illness and disease. And similarly, I think it's important for us to take a look at what's the epidemiology of substance use disorder currently. And this is the most recent data or the numbers that we have nationally here, and looking to see about 16.5% of folks in the United States above the age of 12 have, again, reported substance use in the past year. And what we see here that alcohol, drug, and marijuana use are the most commonly used substances among adults and adolescents here in the U.S. And then specifically focusing on the rise of opioid use disorder. Again, we know that the opioid use epidemic has really come in three different waves. The early rise with the increased rise of prescription opiate, then a rise of heroin overdose deaths, and what we've been seeing now, really for the past decade, is this rise in synthetic opiates, including fentanyl and carfentanil across the board. And again, when we think about nearly 650,000 people have died from an opiate overdose between 1999 and 2021. About 220 people die of an overdose each day here in the United States, and nearly 88% of all overdose deaths are linked to synthetic opioids, specifically fentanyl currently. And then when we think about, who is being impacted by drug overdose deaths by race and ethnicity, again, looking at differences between 2020 and 2021, we are seeing, again, disproportionate impact, again, in certain areas and in certain parts of the country and certain communities as well. I put this graph up for a few different reasons. I think, as an HIV doctor, I find this graph to be really compelling as we look at the HIV disease curve. So just to think about this, this is the leading causes of death among young people, so ages 25 to 44, between 1987 and 2020. And what we see here, that HIV disease in red here, from the late 80s into the early 90s, saw this exponential rise of deaths, young people in their 20s, 30s, 40s, dying of this disease. And what we saw is right in the early 90s, around 1992, an inflection point, and that's really our science and our ability to create and combine antiretroviral therapy to let people actually live. And what we saw is, since that, a steep decline and into an ongoing decline of death of young people related to HIV, to the same order of magnitude that we see of young people dying of other chronic conditions in general. I think this is, an amazing illustration of the power of science and advocacy in really, reaching preventable deaths in general. But there's another story that this graph says. And looking at the blue, both solid line and dotted line, is looking at unintentional injury, which includes car accidents, et cetera, but also includes drug overdoses as well. And so again, looking at the dotted line is actually a subpopulation of the dark line of unintentional injury, looking specifically at overdose deaths. And what we see here is, in that same period of time, now an exponential rise of young people dying of drug overdoses. These are people in their 20s, 30s, and 40s dying of drug overdoses. I think as someone practicing in 2024 who was coming of age during the HIV epidemic, I always wonder what would it have been like to practice during the height of the HIV epidemic. How would I have been able to take care of patients and think about the lives of my patients then? And one of my mentors when I was in Boston made a great point in saying, you don't have to imagine that. We're living in that right now. that in the year 2021, more people have died of an unintentional drug overdose than people dying of HIV at the height of the HIV epidemic. In fact, nearly twice as many people have died of drug overdoses in the past year than have died of HIV at the height of the epidemic. So just as the way, that we think about and judge people of how they chose to respond or not respond to the HIV epidemic is exactly how we will be judged and thought of how we decide or not decide to interact or engage with the current opioid use epidemic. And it's important to recognize that these problems are not separate. That substance use disorder, mental health issues, HIV, STIs, these don't live in silos. They are actually intersecting epidemics that interact and impact one another itself. And they are impacted by downstream issues like systemic racism, homophobia, social determinants of health, transphobia, lack of housing. These all impact each of these epidemics in unique ways that intersect with one another, which then really causes a syndemic. So what is a syndemic? So this is thinking about, again, how these separate epidemics are all interacting with one another, that the HIV epidemic, folks who are vulnerable to HIV are vulnerable to STIs, folks who are vulnerable to substance use disorder are vulnerable to mental health issues, to HIV and STIs, that we can't treat each of these in its own sort of category without thinking of one another. And in the same way, these downstream issues, these upstream issues that impact will have an increased synergistic impact on affected communities downstream. So what are ways that we can sort of address syndemics is really thinking about putting people first, focusing on equity, again, putting money where the epidemics are, leveraging policy as a public health tool, and really prioritizing innovation. Trying to think about how can we co-locate services, specifically when we think about people with substance use disorder, how can we co-locate HIV and STI treatment and prevention in this space? I like to use Scott County, Indiana as a case study. So for those of you not from the Midwest, Scott County is a rural southern Illinois, southern Indiana county, which was really the canary in the coal mine that saw the largest cluster of new HIV cases in this country in nearly a decade, and all clustered in a population of folks who inject drugs. This was about 442 cases of HIV that were linked in this small county in general. There was a great sort of case study done in the New England Journal, looking again at the timeline of when we started to notice this cluster, what was our cluster sort of response, and then on the bottom here, looking at the new diagnosis per week of testing itself. Then Governor Mike Pence of Indiana was a large skeptic of harm reduction policies, and specifically syringe exchange policies, and actually withheld syringe exchange policies for several months into this outbreak cluster. However, when the government of Indiana finally relented and allowed syringe exchange to start around April 2015, look what happened. Look at the rates of new diagnoses from April 2015 onwards. The cluster essentially was extinguished. Looking at this really shows the power of harm reduction and concerted harm reduction in helping, again, us respond to syndemic infectious diseases, and specifically in areas of the country that don't have access to preventive services like other metropolitan areas. And like I mentioned, Scott County, Indiana was really the canary in the coal mine. Since then, we've seen multiple clusters of new HIV cases across the country, both in rural, but also in urban areas in the West Coast, Midwest, and East Coast altogether. And that really goes into thinking about how HIV and potentially other infectious diseases like Hep C are transmitted. This is looking at per act risk of HIV and Hep C transmission per 10,000 acts. And so when we look at receptive vaginal intercourse for HIV, it's about 8 transmissions per 10,000 acts. For injection drug use for HIV, we're looking at about 63 infections per 10,000 acts. For receptive anal intercourse, about 138 per 10,000 acts. And for injection drug use, with Hep C, about 250 transmissions per 10,000 acts. Just gives you an idea of how transmissible each of these infections are by mode of transmission itself. So, when we think about specifically injection drug use, we know that nearly a third of all folks who inject drugs share injection equipment. That either they don't have access to clean syringe exchange, or they don't have access to affordable or free syringe exchange programs. And in general, we notice that syringe exchange or needle sharing is more common amongst young people. That nearly half of people ages 18 to 24 share needles. Same with those up to the age of up to age of even 40 in general. And we know that sharing needles, syringes, and other injection equipment puts people who inject drugs at risk for HIV and other infections like hepatitis C. And we'll talk about even other pathogens we think of more being sexually transmitted. And again, when we think about HIV diagnoses among people who inject drugs, we are seeing a rising rate, a modest rise in specifically women, and we are seeing a rise in white Americans as well. And there's different ways that substance use disorder impacts HIV transmission. So there's direct ways, like we think about syringe exchange, through needle sharing, et cetera. But there's also other ways that substance use can impact HIV transmission. We know how heavy alcohol consumption can be linked to sexual disinhibition and behaviors that increase likelihood of acquiring HIV, whether that is lowering rates of ART adherence or ability to negotiate condom use while intoxicated. Same way we think of methamphetamine and club drugs like MDMA, ecstasy, ketamine, and even poppers in general can increase likelihood of HIV. Specifically, again, it can be difficult to think about the timing of drug use and sexual behavior, but we know that polydrug use is common among users of club drugs, and it complicates analyses. But again, thinking about sexual disinhibition, inability to negotiate barrier methods of protection like condoms, and also decreasing rates of ART use among folks living with HIV specifically. When we think about biomedical interventions that can prevent HIV, we think about pre-exposure prophylaxis, right? So we think about antiretrovirals taken specifically here on a daily basis to prevent HIV in terms of HIV sexual transmission. The Bangkok tenofovir study was the first study looking at oral PrEP or tenofovir emtricitabine as specifically among folks who inject drugs in Thailand. They recruited about over 2,000 persons inject drugs, and they saw a 49% reduction of HIV in those who were on a daily oral pre-exposure prophylaxis medication. And specifically, when they were able to look at adherence by blood spot testing to see of those people on PrEP, how many actually had detectable drug levels, and those who had detectable drug levels had a 74% reduction in HIV acquisition. So again, knowing how PrEP is a really powerful tool, but highly linked to adherence, as we know, with sexual transmission for HIV as well. And so the CDC has really updated its clinical guidance for pre-exposure prophylaxis in 2021, and have really continued to think about people who inject drugs as a priority population to reach for pre-exposure prophylaxis. And these are people who inject drugs who have an HIV positive injection partner who share injection equipment. And again, though, thinking about this endemic, people who inject drugs are also sexually active. And oftentimes people who inject drugs might be trading drugs for sex, or again, don't have the agency to negotiate a condom use or choosing of partners in terms of their own risk of HIV. And so even though someone's injecting drugs, we really need to ensure what is going on in terms of sexual transmission of HIV as well. And again, thinking about pre-exposure prophylaxis in both these lenses. One benefit we have is the USPSTF since 2019 has given PrEP a grade A recommendation for persons at high risk of HIV acquisition. This has helped dismantle a lot of barriers and obstacles in terms of accessing HIV biomedical prevention, both in terms of health insurance coverage for medications themselves, but also for cost of testing, as well as cost of medication visits and lab visits. This is and will be under ongoing and current threat in certain parts of this country that we need to be able to prepare for. And if we have time at the end of the talk, we can talk a little bit more about that as well. So what is happening in terms of, PrEP and HIV transmission among folks who inject drugs? We know specifically women who inject drugs have higher odds of HIV infection than men. We know women who inject drugs are more likely to have higher sexual and injection exposures, as well as concomitant and overlapping exposures as well. We know women who inject drugs are often unable to negotiate safe sex practices that would especially benefit and especially would benefit the most from PrEP. And we know primary care docs are more likely to report decreased willingness to provide PrEP to people who inject drugs than any other risk group. While we have a ways to go in thinking about HIV prevention across the board in primary care. It is even further that we have to go specifically looking at people who inject drugs, that people still are reticent about thinking about PrEP among this population than even anyone else. In 2021, less than 1/4 of Black and Hispanic and Latino people who are eligible for PrEP were prescribed it, compared to 3/4 of their white counterparts. So again, not only disparities and inequities between people who inject drugs and people who do not, we see disparities and inequities in PrEP uptake specifically by race and ethnicity, by gender as well. Again, thinking about these sort of overlapping epidemics, these overlapping intersectional identities that impact someone's ability to access preventative tools that can prevent HIV infection. And then we have an issue with the PrEP continuum. So this is looking at, again, the PrEP continuum among people who use opiates in South Carolina over a period of time. They saw, again, in their in this clinic that when they screened folks, they had everything in place to start people on PrEP, and they found about 60% of their population was eligible for PrEP, and in terms of folks who have opioid use disorder. Of that 60%, less than half had even heard of PrEP. And then of the percentage that even heard of PrEP, only 18% were actually interested in PrEP. Of that, even fewer were actually prescribed PrEP, and even fewer of that were initiated PrEP. And then at 3 months, none of them were retained in PrEP. So this is not even just a conversation about starting someone on PrEP or even thinking about PrEP itself. Now it's then becoming, now that you started on PrEP, how can you continue to engage populations on pre-exposure prophylaxis? I think a lot of populations have been left behind in the conversations around HIV PrEP. And part of that is the fault of messaging, part of that is the fault of providers like myself, and part of that is the fault of public health. But I really think we need to really get ahead of the curve at this point and thinking about how HIV prevention is a tool for everyone. It's not just a tool for MSM and for queer people. It's a tool for literally anyone who has sex, anyone who injects drugs should know about PrEP and think about how biomedical prevention can be a way that they can protect themselves. Then in 2021, we had our first injectable or long-acting PrEP option available, Apretude or cabotegravir for PrEP, which is every other month injection to prevent HIV. Data supporting this was from 2 clinical trials, HP2N083, which was comparing the efficacy of long-acting cabotegravir as an injection given every 8 weeks compared to daily oral TDF-FTC or Truvada for PrEP. They recruited nearly 5,000 cisgender men and transgender women who had sex with men across 43 sites across the globe. And what they found over the course of 3 years, only 50 incident infections. What this tells me off the bat is that, out of 5,000 individuals across the world, followed for 3 years, only 50 incident infections tells me both of these options must be highly effective in preventing HIV. And what they found was 38 incident infections in the oral PrEP arm and 12 incident infections in the injectable PrEP arm. And they found that cabotegravir was highly effective for HIV prevention and superior to oral PrEP in cisgender men and transgender women. The HB208-4 study was its sister study, which is comparing long-acting cabotegravir given every 8 weeks compared to daily oral TDF-FTC for HIV prevention among cisgender women in sub-Saharan Africa. Again, they recruited about 3,000 cisgender women, average age of 26, followed over the course of 2 years, only 38 incident infections in a high prevalence setting. This is telling me that both of these options must be really, really effective in preventing HIV. And that's what they saw. 34 incident infections in the oral PrEP arm and only 4 incident infections in the injectable PrEP arm. That cabotegravir was highly effective for HIV prevention and superior to TDF-FTC in cisgender women. When we think about, now we have multiple options for PrEP. We have oral PrEP options, injectable PrEP options. This can be confusing thinking about, what is the right one for the patient. The right one for the patient is the one that the patient will use, the one that aligns with the patient, the one that the patient takes. While increasing the number of PrEP options can make counseling more difficult, make counseling more complicated, create a lot more questions, in the end, this empowers patients by giving patients choices of how to protect themselves for HIV. Do you want a shot? Do you want daily pills? Do you want on demand? All of this allows patients to think about what is right for them and what works for them itself. It's really about shared decision-making, laying out all the options for them and seeing what's most feasible for the patient. We make a lot of parallels to birth control and understanding that as we have more and more birth control options, we're able to empower our patients to think about how they can prevent pregnancy or think about their own family planning. What's interesting now is thinking about long-acting HIV prevention, specifically in the setting of substance use disorder. We have long-acting options that are used in mental health, specifically around antipsychotics, but also around medications like Vivitrol, a medication used for opioid use disorder. And there's a lot of areas that we can actually think about where how long-acting HIV prevention might be better for folks with substance use disorder. Thinking about long-acting HIV prevention as a way to, overstep or step around issues around adherence for daily medication, which can be very difficult for someone who with active substance use disorder. And then specifically, I think it's important to still recognize something we haven't talked about yet is still STIs. Another infectious pathogen that we think about overlapping with opioid use disorder. This is data out of St. Louis and Kansas City regions looking at rates of syphilis, early syphilis cases among people who inject drugs over time, and seeing, again, higher and higher rates of syphilis among this population. And again, it's really hard to oftentimes tease out what is, syphilis transmission due to injection, because syphilis is still a bloodborne pathogen. But again, understanding that injection networks and sexual networks often overlap and can be very difficult to divorce the two. Again, going back to this idea of this endemic, that you cannot think about HIV, substance disorder, STIs, hepatitis C as their own individual infections that live on their own and sort of progress on their own. They're all impacted and interact with one another, and really control of one can impact and inform the control of another. By co-locating both HIV and STI services, I'm able to control both. By having HIV and STI screening at my methadone clinic, I'm able to think about HIV and STI treatment and prevention, as well as substance use disorder. Again, having the ability to have these types of services offered together is a way to have cross-cutting effects in public health. The last part of my talk, I do want to talk about doxy-PEP and thinking about, again, biomedical intervention and thinking about STI prevention. And thinking about, is doxy-PEP the future of how we think about STI prevention in general? So what is doxycycline? So doxycycline is a second-generation antibiotic. It's widely available, inexpensive, well-tolerated, with a pretty broad spectrum of antimicrobial activity. It's used currently to treat multiple STIs. It's currently the first-line therapy for chlamydia infections. It is alternative therapy for syphilis infections. It used to be used to treat gonorrhea, but no longer used due to rising tetracycline resistance. It is a teratogen, meaning it's contraindicated in pregnancy. And this is really related to older versions of doxycycline called tetracycline. And even a review of our teratogen information system has concluded that therapeutic doses of doxycycline are unlikely to pose a substantial risk in pregnant persons. Data is still insignificant to say that there's no risk, and therefore doxycycline is still considered a teratogen and recommended to be avoided in pregnancy. The first data that we have most recently looking at, pre-exposure prophylaxis or thinking about prevention of STIs with doxy was this randomized controlled pilot, a very small study of men who sex with men in San Francisco who are living with HIV. Only 30 subjects were block randomized to either taking doxycycline on a daily basis, so 100 milligrams of doxycycline taken every day for 36 weeks, compared to those that were just randomized to incentive arm, essentially received incentives for remaining STI free. What they found was a 73% reduction in syphilis, gonorrhea, or chlamydia in those taking doxy on a daily basis versus those not taking doxy at all, with no difference in reporting sexual behaviors between the two groups. This was sort of changed and looked in separately in a PrEP study in France in 2018. And so the RNS Aggregate study is a very large PrEP study in Paris, which was recruiting MSM and transgender women without HIV, about 200 of those, who were then randomized to take doxycycline as a post-exposure prophylaxis. So this is actually looking at a single dose of doxy after sex, a bit of a higher dose, 200 milligrams, taken 24 hours after sex, compared to individuals with no prophylaxis. Again, this is a PrEP study, so all of these individuals were not living with HIV and were on an HIV PrEP medication in addition if they were randomized to a doxy post-exposure prophylaxis. The primary endpoint they were looking at was the occurrence of a first STI, whether that be gonorrhea, chlamydia, or syphilis, during a 10-month follow-up period. What they found was doxy-PEP, so doxycycline taken one time after sex, reduced the occurrence of a first bacterial STI by about 47%, with no significant difference in reported sexual behaviors. Specifically for chlamydia and syphilis, they saw 70% and 73% reduction, respectively, in those who were taking doxy-PEP. They saw no rates of gonococcal infection between the two groups did not differ. So while doxy-PEP decreased significantly chlamydia and syphilis, they did not see a significant decrease for gonorrhea. They were looking at genotypic markers for increased resistance to tetracycline. They could not observe that, at least in a short 10-month period. And then specifically looking at the two groups, there really was no difference in sexual activity. There was no difference in the number of sex acts between those who were getting PEP versus not getting PEP, no difference in number of sex partners, and no difference in common sexual encounters between the two groups either. So I'm seeing in the chat box questions about resistance, and as an infectious disease doc, that is obviously something I'm highly concerned about. Thinking about if we're increasing, exposure to antibiotics, isn't that going to increase antimicrobial resistance? And it's important to think about a few things. First of all, one thing to keep in mind is doxycycline or antibiotic prophylaxis is not new and not something we just use for STIs. We think about antibiotic prophylaxis for a host of other illnesses and infections in general, specifically post-exposure prophylaxis for things like Lyme disease, scrub typhus, malaria, etc. Specific to STIs, we know that there is already tetracycline resistance in gonorrhea, and that we know that is higher specifically in men who sex with men, a priority population that we would think about this intervention. For chlamydia, we know that treatment failure for chlamydia can occur in a minority of cases, but clear resistance to doxycycline or tetracyclines is not clearly identified. Mycoplasma genitalium, this is an emerging cause of urethritis in MSM, does see increased risk of resistance to doxycycline or tetracyclines in general, and that is a real concern that folks have. Unfortunately, we have no established standards of identifying or measuring doxy resistance currently, whether that be for gonorrhea, for chlamydia, for mycoplasma genitalium, or for syphilis. And there's still a concern that we have bacteria that live on our bodies that is part of our commensal flora. This is normal bacteria that we have that live in our gut, that live in our skin, that can be impacted by tetracyclines. And that's important for us to think about what that can be. The doxy-PEP study is one of the more recent studies that have come out here in the United States, looking at the intervention of doxycycline post-exposure prophylaxis in 2 clinics in Seattle and San Francisco. This was looking at both people living with HIV as well as those who are HIV negative on PrEP, but specifically only looking at people who assigned male at birth, so men who sex with men and transgender women who have sex with men. Their inclusion criteria was they had to be assigned male sex at birth. They had to have at least one STI in the past year, and they had to be endorsing condomless sex with at least one male partner in the past 12 months. They recruited about 327 folks on PrEP and 174 folks living with HIV. About 33%, a third of them were non-white, 30% were Hispanic. The median number of sexual partners was about 9, and about 2/3 had endorsed substance use in the past 3 months in general. They found about 87% of all condomless sex acts and those that were getting doxypep were covered, meaning if they had a condomless sex act and they were in the doxypep arm, that they took their doxycycline dose. They had a median of 7 acts per month. About 16% took more than 20 doses a month, and 30% took 10 to 20 doses a month, but the majority of folks took less than 10 doses a month in general. And what they found was a significant decrease, risk reduction in STI incidence per quarter across the board. And what they found was, unlike IPERGAY, they found decreases in all 3 STIs, decreases in gonorrhea, decreases in chlamydia, and decreases in syphilis in both people living with HIV, as well as HIV negative cohort on PrEP. Significant declines on the orders between 60 to 80% reductions in each of these infections. And again, really, this is sort of plotting it out, showing the major difference between doxycycline. So it's the Kaplan-Meier curve. The curve that is lower is a significant lower number of new infections. And they, again, saw the doxycycline group in both people with HIV, as well as those on PrEP, saw a significant reduction compared to those that were just in the standard of care arm. The French came back with a new study called DoxyVac, which was looking at, again, doxypep versus no pep. And they were actually also looking at a meningitis vaccine to see if that would be effective in preventing gonorrhea. We can talk about that in a little bit, but in that essentially thinking of other ways of preventing STIs. But what they found specifically is now here they found in the DoxyVac study significant reductions in first-time chlamydia and syphilis infection and those that were getting doxypep. And now they did actually see a modest decline in first-time gonorrhea infection, as well as first-time Mycoplasma genitalium infection, and those that got doxypep did not get doxypep. So again, population of men who sex with men and transgender women seeing significant declines in STIs related to doxypep use itself. So what about women, right? And so this study, the DPEP study, was looking at cisgender women in Kamuzu, Kenya, looking specifically at doxypep among women who are taking HIV PrEP in Kenya. And what they found, unfortunately, was no difference in first-time incident STI or first-time incident chlamydia in these women who were taking doxypep versus not taking doxypep. There are a few reasons to think about why did we not see a good effect in cisgender women. There are concerns like, is there an anatomical issue? Is there, difference in how much drug gets into endocervical tissue and rectal tissue in women than it does in men? I will say, since this study, there have been in vivo studies have shown that this is not the case, that anatomically, thinking about doxycycline concentrations is essentially the same between these groups. There was concern for resistance, like, is chlamydia or syphilis or gonorrhea more resistant or higher rates of resistance in Kenya? They did a study that showed that that was not the case globally here as well. And what really boiled down to was adherence. That when they actually did drug levels of the women who were in the intervention arm, meaning the women who are supposed to be taking doxypep after sex, nearly 2/3 of them did not have any detectable doxycycline in their system. So I think it really comes down to an adherence issue here, thinking about is there an issue with women being here? And what I did not put in here, adverse events. There were reported social harms, domestic violence, and specifically intimate partner violence that was higher in the group that was assigned to doxy-PEP. So really thinking about needing a really woman-centered approach of future studies related to doxycycline for post-exposure prophylaxis. And I will just make my own commentary. I don't think we need to go to Kenya to be studying syphilis in women. I think we have higher enough rates of syphilis and STIs in women here in the United States that we should be able to, our government should be funding these types of studies here as well. And so this goes back to sort of what's, when we think about doxycycline, prophylaxis for STIs, what's the target population here? We know that the large proportion of STIs occur in folks with repeat infections. There's a study out of Massachusetts which showed that only 0.2% of the general population acquired more than one repeat STI in the past 2 years. But that 0.2% of the general population that had more than one STI accounted for nearly a third of all STIs in the same period. So you have this core group of folks that are getting more than one STI in a short period of time. And this is not even thinking about all the downstream transmissions that one person might be responsible for. So any novel STI prevention has to start with this group first. And that's really what we're thinking about, that really thinking about groups of folks who have more than one STI. These are the people that we need to be focusing our interventions around doxycycline for. So where do we go from here? So several questions still remain. All of these studies, IPROGAY, doxy-PEP, doxy-VAP, these are all short-term studies. The longest one was maybe 12 to 14 months. We need longer-term safety, adverse event data, and resistance data that needs to be collected. We need to clearly identify a target population, but I think we really have identified that. There are now clinical guidelines that are under review at the CDC, which is looking specifically at men who have sex with men and transgender women who have had more than one STI in the past 12 months and have sex with other men without condoms should be considered for doxy-PEP. I think we have a population that we have crafted right now that we can hopefully grow with better data. Again, we need to continue to monitor resistance to STIs, gonorrhea, chlamydia, syphilis, but also to other commensal organisms like staph and strep that live in our skin and our bodies. And we need educational efforts. If we're going to be using terminology like PEP and PrEP that have been so historically linked to HIV, we need to be able to distinguish it from STIs. We don't want people to be confused that HIV PrEP will protect them from STIs, the same way we don't want people to be confused that doxy-PEP would prevent someone from HIV. But I think it's important for us to recognize that the urgency of the ongoing STI burden, specifically among MSM and trans women, compels us to act now. We can't wait 5 to 10 years until we have great resistance data before we can really think about acting right now. And I will say this intervention is already occurring. People are already taking doxy-PEP. And so it's really important for us to be able to really provide adequate guidance to think about that. And I can't help but think, is this sort of deja vu all over again? There are so many striking similarities between HIV PrEP, that rollout that began, over 10 years ago, and what we're seeing with doxy-PEP right now. These are both novel biomedical interventions with significant impact on priority populations. There's concerns for antimicrobial resistance and misuse. For those of you who remember the conversations that we had around HIV PrEP 10 years ago, people were wringing their hands and really concerned. Now that we're going to be providing, antiretroviral medication to large groups of people, is that going to cause more resistant HIV? Are we going to see higher rates of HIV resistance in our community? That has borne out to be false and not true, but that was a major concern that folks had. And there are equity concerns for uptake and utilization. We are still, like I said, playing catch up with HIV PrEP a decade later, trying to engage people who inject drugs, trying to engage women, trying to engage non-white individuals in the United States. And we still have not made up that difference yet. And data in cisgender women are lacking. Our first studies on HIV PrEP did not include any women. And so again, we are here again at the same point that we are not having great data for women when we think about STI prevention, and women need it just as equally as anyone else. So what's different now? Well, we are seeing what's interestingly data out of a large sample off of Grinder actually showed that more Black and Latino men who were surveyed using the Geo Network social app were more interested in doxypep than their white counterparts. There are these signals of higher interest in populations that we have not been able to actually engage in adequately before with HIV PrEP. And is that that we can use for leverage using doxypep for them? But what's really important is we should know better. We need to really learn from the mistakes we've made with our HIV PrEP rollout and these mistakes that we're continuing to feel the reverberations from a decade later, and making sure that our implementation of doxypep has equity in mind and built from equity from the ground up in general. And specifically in the same way that we should know and do better and be able to fund studies specifically in cisgender women for doxypep. Like I said, we don't need to go to Africa to be studying syphilis, gonorrhea, and chlamydia in cisgender women. We are having those epidemics currently in this country right now. And if we want to get to, reducing congenital syphilis cases in this country, we need to be offering women with pregnancy potential the ability to protect themselves from STIs. So what are some best practices in integrating sort of HIV and STI care for clinicians and educators? We need to increase awareness, decrease avoidance, and engage with our patients. Role model approaching patients with interactions with empathy. Again, language matters. Emphasizing, that we're not helpless, that we have harm reduction and treatability tools at our disposal, and really not being afraid to involve and engage trainees. I think a lot of us have trainees under us, and trying to remember how we can think about engaging the future workforce in this type of work. Great. Thank you so much for inviting me to talk today. And again, I'm happy to take any questions and go from there.
Thank you so much, Dr. Hazra. We do have a few questions in the pod, and I'll address the first one. And this question came in early on after maybe your first couple of slides. It asked, what year are your statistics from?
Yeah. So all the HIV statistics are the most recent HIV surveillance data that we have, which is looking at the 2021 year. So our HIV surveillance has always lagged behind and actually had been further lagged behind because of COVID in general. So the most recent data we have about HIV diagnoses is actually from the year 2021 that was published in 2023. So we should hopefully be getting 2022 data later this year, which I'm hoping to get soon. The STI data is from 2022. It's a little bit more recent in general. And then the opiate data that we're looking at, specifically the intersection of opiate disorder and HIV, was from the HIV data from 2021.
Okay, we have another one. It says, good afternoon. Do you know where to get fentanyl test strips to be able to give to clients using drugs like crystal meth for them to be safe in the use of substance and clean from fentanyl?
Yeah. So I think I have resources here in Chicago that we look at. I think it's really important to identify sort of CBOs and other sort of harm reduction and recovery organizations in your area that's able to provide syringe exchange or even fentanyl test strips. In Chicago, we have amazing resources like the Chicago Recovery Alliance, as well as TPAN, that's able to distribute fentanyl test strips for free for folks. You bring up an amazing point. These synthetic opiates are now being sort of mixed into the drug supply itself, from things like crystal meth, but even into innocuous things like marijuana or even like Xanax and benzodiazepines that are sold outside prescription pharmacies, but really trying to make networks and whatnot with recovery and alliances in your areas, and to really figure out how to get those test strips in your areas. Yeah.
Okay,
Yeah,
great.
Chelsea
Thank
asking
you.
where you're located. Yeah, because I feel like there's a lot of people on this call that'd be more than willing to help.
And so there's a lot of resources in the chat. People have dropped some resources in the chat as well. I wanted to say really quickly, the evaluation link has been dropped in the chat. If you could take a moment to complete that, that would be great. Like we said, your feedback is very important to us. And in order to receive a CE, you must complete the evaluation and had been on the call for at least 80% of today's session. Also, Dr. Hazra has agreed to stay on a little past the time today, if you have time, because we do have quite a few questions. And I'll go ahead and jump to the next one. A 2020 NIDA supported study showed that as many as 1 in 3 new HIV transmissions among sexual and gender minorities who have sex with men were in people who regularly use methamphetamines. Many participants reported using methamphetamines to enhance sexual experiences, sometimes called partying and playing, which is facilitated by the dating and hookup apps used by LGBTQIA+ populations such as Grindr, Adam for Adam, and etc. These represent a staggeringly large percentage of new HIV infections and requires a public policy response such as marketing, awareness, and advocacy. To your knowledge, what is being done about this portion of the syndemic?
Yeah, I think methamphetamine use itself and crystal meth use for a lot of reasons that was mentioned in the question is highly linked to HIV transmission. The PMP culture itself, it's high number of sexual partners, but also the length of time that someone is having sex themselves. That's why oftentimes people are using crystal methamphetamine so they can have sex for very long periods of time. So it's not only the number of exposures, but then the length of exposure itself. It really puts people at high vulnerability for HIV transmission. Crystal meth use and the crystal meth epidemic that we see here, again, is part of this syndemic that we're talking about. It is also probably the most challenging substance, I would have to say, that in my clinical experience to engage people with. But what has been looked at now is thinking about long-acting options for PrEP, specifically for this population. That when someone is partying, playing, or PMPing, they're not going to remember to take their HIV medications. They're not going to remember to take their PrEP medications. So giving them access to long-acting medications for both treatment and prevention is really important because that's potential ways of protecting themselves. The CDC has resources for sure, looking at for folks who are suffering from crystal meth use, but they can definitely be doing more, and our federal government can definitely be doing more to support studies and interventions for this population. But I will say again, in my clinical practice, I've just seen lives and communities completely decimated by crystal, and it's just something about this drug specifically that is so different than some other substances.
So someone to piggyback off of that asked in the chat, doesn't crystal meth also impact immune system to make someone even more susceptible to infection, like the drug itself, not just the sexual contact?
So yeah, so it's specifically in people living with HIV, ongoing or chronic crystal meth use can actually lead to lower CD4 counts, irrespective of folks staying or taking their medications themselves. So there is some data to definitely to support that. Yeah, and
Okay.
some people have put some great chemsex tools in the UK. I think Europe, has been dealing with chemsex for a bit longer than we have, or has had a lot more experience with it. And they have a lot of great tools out of UK and France, I would say as well.
Okay, here's another one. Has there been any specific research on whether injectable medication or even lab drawn can trigger people who are current or former needle users? If so, are there non-clinical counseling strategies to counter this?
That's a really great question. I will bring up one thing. So the injection medications are injected intramuscularly. So they're not IV medications. It's not like an IV infusion and in general. But even oftentimes the site or being around needles themselves can definitely be triggering for folks who are in recovery. To my knowledge, I actually don't know of people exploring that or actually thinking about what the impact of injection medications for both treatment and prevention, how that would interact folks who are in recovery from injection use disorder. That's a really interesting question. I don't know of anyone, but again, this is not something that's going directly into someone's vein and you're injecting medication. It's usually something like going into their buttocks. So if you ever given someone like a shot in their arm for like a vaccine or treated someone for syphilis, it's similar to that mode of administration.
Okay. Next, we have how knowledgeable are local health departments and other providers in prescribing doxypep?
Depends where you are. I mean, I really pushed our city of Chicago to create guidelines And I'm happy we've been able to publish them, and they're publicly available. There are other cities, New York City, San Francisco, Seattle, have created their own guidelines right now. What I'm hopeful for is with the CDC final recommendations, so the CDC put out their guidelines for public comment last fall. Hopefully they'll be published now after they take in those comments. They got nearly like 1,300 comments from the public on their guidelines. Once they incorporate all of that, I'm hoping we're going to have some guidelines established by the end of the year. And that is what I'm hoping other local health departments that may not have as vocal advocates can refer to for doxycycline prophylaxis.
And Dr. Hauser, we have a question. Would you mind
Oh, yeah.
linking the guidelines that you've
Of course, of
developed?
course, of course. Let's see if I can. I can link the Chicago one. That's gonna be the easiest one for me to find first. Actually, yeah. Let's do.
Great, thank you. All
And
right, we
I'm
have a
gonna,
couple more,
yeah,
or go ahead. Sorry.
I'm gonna quickly link something else. Um, this is a review that, okay, actually, I'll link that later. Go ahead, sorry.
Okay, next question. The upcoming studies for Purpose 3, long-lasting prep for cis women, and Purpose 4, long-lasting prep for people who inject drugs, may help to address some of these concerns. How can we effectively promote these studies for people who want access and are interested in research?
Yeah, so I think Purpose 1 and Purpose 2 have done a really good job in, I think, finding sites specifically. And I think Purpose 1 will actually give us a lot of data specifically in cisgender women, which is obviously what is so needed. I think if you're familiar with your own sites themselves, so they're no longer recruiting new sites, and they're likely going to be finishing their enrollment relatively soon. I think Purpose 2 is already done with enrollment, or Purpose 3 might be done with enrollment in general. Uh, but I mean, I think, when we think about lenacapavir PrEP, the every 6-month injection now that's being studied in these trials, I think once we get data on these different populations, that's going to be so important. But if you go to the Purpose websites, they have all the sites listed. So if you're in an area that has that site, you can often ask that site for recruitment material that you can keep in your clinic or in your area. So folks can be able to be enrolled. But from what I understand, most of the sites have not had an issue with enrollment, which is great. And some of the sites actually have reached their enrollment targets and actually have closed. Oh, Jared's saying, okay, you're continuing to enroll. Okay, great.
And we do have one more question, and it asks, is this design available to the entire public, including people without HIV of any gender? This came towards the end of the presentation. Would the person who asked the question like to unmute and elaborate a little bit on that? If they are still on the call? They may not be on anymore, so I'm not even sure.
Okay. Yeah, I'm trying to think about what I was thinking about. What I was saying around that time. See my last few slides.
Oh, their hand is raised. Let's. Are you able to unmute? Well, we do have another hand raised, and I'll go ahead and allow this person to unmute so they can ask their question. Um, Looks like the hand isn't raised anymore. Sorry. We'll receive the slides in our emails. The slides will be made available um, on NAHUD's website. And a PDF of today's presentation will be available as a resource on NAHU's website within 1 day. It will also be included in the post-webinar email sent out tomorrow. So yes. I did see some virtual hands, but I do not see them anymore. So if we don't have any more questions, I think that is it, Dr. Hazra. Thank
Yeah,
you
no.
so much for being here today. We
Yeah,
really
no, it's my
appreciate
pleasure.
it.
It's so great talking to you all.
Yeah, we had a lot of wealth here today.
Yeah. Have a great Friday and have a great weekend, everyone.
Thank you, you too.